So as a transplant community, whether you're a doctor, a nurse, a parent or a patient, one of the questions we always ask is, after the transplant, do I have to be on these drugs forever? Can I withdraw them? And there's been some new and interesting data in this area, and to tell us a little bit more about that is Dr. Michael Stormon, who's the Senior Paediatric Hepatologist at the Westmead Children's Hospital. Anything else I need to say about you? It's a bit of a yahoo, but apart from... No. Thanks, Michael.
Thank you, Dame Juanita, for coming up from Melbourne to chair the session. So one of the questions is that we often get asked is, do we need to be on immunosuppression for the rest of our lives? And in the transplant community, this is known as the Holy Grail, with all due respects to Monty Python. So we've just heard from Albert, 30 years history of liver transplantation in Australia. And really, if you look back 30 or 40 years ago, it has been one of the modern medical miracles. As I often say to families, this is not a cure. We're swapping one disease for another. We obviously try and make the new disease much, much better than the old one. And generally we succeed. But immunosuppression has a lot of side effects. The dogma is that you're on immunosuppression for life, and some of the side effects are listed there: infection, kidney dysfunction, a range of metabolic disturbances, the risks of malignancies long term, and in some situations what we call immunological mayhem, as we tinker with the immune system to suppress rejection. So the liver is quite a unique organ, which Albert alluded to. It can regenerate, and in situations where we've done live donation, we know that the liver will grow back within 6 to 8 weeks. Liver transplantation surgery is the most complex of all transplantation surgery, compared to kidneys, hearts, lungs, believe it or not. But having got through that, it's actually the most ideal organ because it's the most tolerogenic, what we call tolerogenic. Episodes of hyperacute rejection, so rejection in the first week after transplant, are rare. Even chronic graft rejection over many years is uncommon. The liver, usually you'd need less immunosuppression to prevent rejection. And we know that when livers are transplanted with other organs, in particular kidneys, but also small bowels, it exerts some sort of a protective effect and prevents rejection of those other organs. So the holy grail of transplantation medicine is so-called tolerance. And one sort of brief definition is that a liver transplant recipient with normal liver function in the absence of immunosuppression. And all of units around the world have got patients who appear to be tolerant. You've got the tricky adolescent who doesn't take his medications. Any adolescents here? Nick? No, you take them, I know, good boy. You've got situations where patients who develop post-transplant lymphoproliferative disease or other malignancies, where you take them off immunosuppression and they seem to tolerate that. And in situations where there's been scheduled withdrawal of immunosuppression. They're not really truly tolerant, but it's really what's called operational tolerance, and this is somewhat of a dynamic state. And true tolerance only occurs if you have what's called bone marrow chimerism, and this is actually quite rare. Chimerism is defined as the harmonious coexistence of donor and recipient. And in basic terms, this requires bone marrow conditioning or bone marrow transplant, myeloablation, chemotherapy, along with liver transplant. People have looked at doing this, but generally the results have been disappointing. This is where you may either do a bone marrow transplant and then do a liver transplant afterwards, or do a liver transplant first and then a bone marrow transplant with the same donor. But when people have tried to do that, generally the results have been disappointing, although there's still work ongoing. There's obviously risks with increasing immunosuppression for bone marrow ablation, and the risks of what's called graft versus host disease, where the engrafted bone marrow actually attacks you, the host. True chimerism has occurred on one occasion in our experience. A few years ago, a 9-year-old girl who presented in liver failure. She had an urgent liver transplant. About 9 months after transplant, she developed severe hemolysis. This is where her red cells were being broken down. It was recognised by Vicky, actually, our nurse, Vicky Germain, came to me and said that she'd changed her blood group. And I said, "Don't be stupid, that's ridiculous." 5 minutes later, I had a breathless haematologist on the phone saying to me she's changed her blood group. And I thought, oh, how ridiculous. So eventually we stumbled across the fact that most of her bone marrow and her immune system was donor, about 98%. And what was happening was that the engrafted marrow from the donor was producing antibodies against her own red cells that were still being produced. So it was a bizarre situation. After much consultation and agonising, we slowly withdrew her immunosuppression, and she ended up with a complete bone marrow transplant. So the whole of her bone marrow was donor, as was her liver, so she didn't need any immunosuppression. This is really unusual, uncommon, so much so that we published that in the New England Journal of Medicine. And if I could figure out how we did it, I'd be living across the harbour there, and I would have travelled here on my boat and helicopter. This is Demi, this is her back then, and now she's a young woman of 21, 22, 23, 24, with her own baby, off all immunosuppression. In fact, she doesn't turn up to see the adults anymore. So there have been a number of studies in tolerance, as Juanita mentioned, a lot of case reports, a lot of anecdotal studies. There's been 3 recent prospective multi-centre trials, both adults and children, and they've reported operational tolerance in those trials of between 40 and 60%, and possibly higher rates in children. One of the key factors that seems to shine through is that the increased time from when you get a transplant to when you withdraw immunosuppression is associated with better outcomes. But we should point out that these are very highly selected patients, which I'll talk about later. And people have tried to identify various factors, genetic factors, immune factors, T cells, which are the immune cells of rejection, which might predict whether you can become tolerant further down the track. And people have tried to identify when do these factors appear? Can we identify them earlier so that you could say in Joe Bloggs, we could take them off immunosuppression early on and be confident that they wouldn't have rejection. Probably one of the major studies was by Sandy Feng, who's a surgeon in San Francisco, a transplant surgeon who's done a lot of work in this area, and she published this study in 2012 and has actually just had a follow-up study accepted for publication in Hepatology, but she published this in JAMA, which is the Journal of the American Medical Association. It was a multi-centre study, and you can see they only had 20 patients. So right from the start, this is a highly selected group. These were children who'd received a live donor. They were more than 4 years after transplant. They had normal liver function tests for at least 6 months. They'd had a normal liver biopsy. They'd been on a single immunosuppressant drug. And in this group, they slowly withdrew immunosuppression over about 12 months. And of those 20 patients, 60% were identified as being tolerant. And this was followed up for between 3 and 5 years after withdrawal of immunosuppression, normal liver function tests, normal liver biopsies. And the follow-up study has demonstrated that all those 12 patients are still tolerant with normal liver biopsies. Again, the time between transplant and immunosuppression seems to indicate a better outcome. And of the 40% who rejected, they all responded well to the reintroduction of immunosuppression. So it appears that if tolerance is going to occur, it would take some time to develop, as much as we can recognise at this point in time. This means that you're exposed to the toxic effects of immunosuppression over that early period. And people have wondered, can you induce tolerance earlier? Jeff McCorn, who's the head of the unit at Royal Prince Alfred Hospital here in Sydney, has done a lot of work in tolerance. And using animal models, he showed that by using early heavy immunosuppression, which is what everyone around the world does, it not only prevents rejection, but it also prevents this sort of immune interaction which might allow tolerance to develop. So therefore they've postulated in the past maybe we should be delaying or minimising the early heavy immunosuppression for the first few days after transplant to allow tolerance to potentially develop. The problem is, and he hasn't done it and no one's really done it because no one's really quite sure exactly what we're doing. These are animal models, and what happens in the lab doesn't necessarily mean what happens in real life. And because we can't identify what factors predict tolerance, then people have tended not to go down that path. One of the new kids on the block is so-called donor-specific antibodies. So these are antibodies that the body produces against what's called HLA, human leukocyte antigens. And the HLA matching is what occurs in other organs like kidney transplants. Now in liver transplantation, we match people by blood group only. We don't look at human HLA matching. Whereas in kidneys, they know that the outcomes are much worse if they don't match them up for their HLA. There has been increasing interest over the last 5 years in donor-specific antibodies and liver transplant recipients, and there seems to be a role in a certain percentage of what's called antibody-mediated rejection due to high levels of donor-specific antibodies. But the jury's still out as to what exactly they mean. We've all got patients who have high donor-specific antibodies, and we've got patients in the clinic with this, but normal liver function tests and normal liver biopsies. So we're not really quite sure of its role in liver transplantation. The other thing I'll mention is protocol liver biopsies, which alludes to the fact that just because you have normal liver function tests doesn't necessarily mean you've got a normal liver biopsy. And doing protocol biopsies, and not every unit around the world does them, it can identify evidence of rejection, even without abnormal liver enzymes, evidence of so-called transplant hepatitis or inflammation of the graft, and perhaps more worrying, fibrosis or scarring in the liver. And studies over the last 10 years have identified significant rates of inflammation and fibrosis in reports of protocol liver biopsies. And probably one of the ones that scared everyone was this study published 10 years ago, 2006, from Birmingham Children's Hospital in the UK, and Helen Evans, who's now in New Zealand, was the lead author on this paper. And if you look on the x-axis, you can see the time in transplant in years, 1, 5 and 10 years, and you can see that the increasing rates of fibrosis and in the dark shading cirrhosis, which was a little bit frightening. And I must say, in our cohort of patients in Sydney, we haven't seen this same degree of damage to the graft. And I know in that study they did use cyclosporin as their main means of transplant of immunosuppression, so that may have had something to do with it. So what's the answer? You've got the patient in the centre. And you've got all these competing factors. You've got, what are the liver function tests? What's the quality of life of the patient and their family? How's the child growing and developing? Are the donor-specific antibodies elevated? What are the side effects of drugs and immunosuppression? What does the liver biopsy show? What is the answer? I don't know. If you look at immunosuppression withdrawal, and this is a quote from Estella Alonso, who's a paediatric hepatologist in Chicago, who's also done some work in withdrawal of immunosuppression. An experimental procedure for which clinicians, patients and families must balance risks and benefits. That makes sense. That's what we seem to do every day. They produce what's called a Markov model, which is a way of analysing based on various assumptions what's the best treatment outcomes in difficult clinical scenarios like this. So based on a number of assumptions, they recognise that if you withdrew immunosuppression, children would have improved survival, improved quality of life, and it would cost less. That sounds great. So what do we do in Sydney? As a baseline, in the clinic, We undertake 3 monthly clinical reviews. We do liver function tests. We measure drug levels. We obviously look for other side effects. I won't go through all the different investigations that one does, which every unit around the world would do. In general, we try and minimise immunosuppression. So as the children grow after transplant, we tend to leave the immunosuppression the same, let the levels drift down, depending, of course, that the liver function tests are normal. We have been measuring donor-specific antibodies over the past few years. And we have been doing protocol biopsies nominally at 2, 5 and 10 years, but that's not set in concrete. And in that way, we're at least monitoring what's going on. What should we be doing in terms of withdrawal of immunosuppression? Well, I think it's evolving. We haven't a firm policy of withdrawal of immunosuppression. I think the increasing evidence is that the longer you are out from transplant, maybe 4 years, if you have normal liver function tests, if you have a normal protocol liver biopsy, if you have low-level donor-specific antibodies, one might then consider withdrawal immunosuppression. But as the quote from Estella said, it's a balance between risks and benefits in consultation with the family. So to finish up, we're still looking for the Holy Grail. We'll keep searching. I think I've got about another 10 or 15 years left in me, so hopefully by that time we will have found the Holy Grail. Thank you.